My name's Deepak Joshi, and I want to talk a little bit about some of the key sort of considerations when we're trying to manage these groups of patients that I think we're going to be seeing more of coming to our clinics. So already my esteemed presenters have talked about the presentation, and it's worth sort of remembering we might be seeing patients in their sort of young adulthood or pure adult populations. Their presentation may be acute or chronic, maybe even presenting with sort of suggestion of chronic liver disease, some of the consequences of chronic liver disease, and it can certainly be episodic as well. And we'll talk a little bit about BRIC and whether this is a true sort of a true description of the disease process. And then obviously there's clear situations where the individual is pregnant. And there's a group of patients with cryptogenic cirrhosis where we feel, we've done enough, but I think these are groups of patients we can be more sort of refined, we can be a bit more sophisticated, and think about where genetics may be sort of playing a role. We've talked a little bit about symptoms, and our patients that we've described have got symptoms ranging from pruritus, which can be severe. It can really affect their day-to-day living, their quality of life. And it can also be very subtle as well, abdominal pain, maybe even cholangitis. And we've already heard from Verena about sort of the LPAC syndrome, where patients have intrahepatic gallstones. And this is a nice case which I was doing an ERC on, where the patient had had numerous ERCs, and we didn't really think about, well, why is this young individual got gallstones in their intrahepatic ducts, as opposed to let's just try and clear them out. So I think that's very important. Obviously, as per Sylvia's case, patients can present with decompensated liver disease as well, with variceal bleeds, ascites, and all the consequences of cirrhosis as well. So my case is one of a 41-year-old gentleman who presented in July of this year. Presented with jaundice and quite severe pruritus. And when they were evaluated in a referring institution, the patient made comment of a previous episode in 2018, but didn't really discuss it in much detail. The family history and social history was negative. There's no history of early onset, gallstones or cholecystectomy or cancer for that fact. But you could tell that this individual's pruritus was severe because they had excoriations, they'd broken through their skin, and when it was sort of discussed in a bit more detail, they weren't sleeping at all. And their biochemical results were quite alarming. They were jaundiced with a bilirubin of 147, raised alkaline phosphatase, but relatively normal gamma GT, but very high serum bile acids. And as you'd expect, this individual underwent MRCP. They actually underwent a PET scan because of the sort of slight concern of a possible malignancy, and they also had a liver biopsy. So fairly sort of standard investigations for somebody presenting with jaundice. And this was their liver biopsy. So they had a sort of bland cholestasis, intrahepatic cholestasis, but no significant fibrosis. And although that was reassuring, we were still left with a young individual with quite severe symptoms. In this individual, their genetics had been sent, and they carried two mutations in the ABCB11 genes, heterozygous for both. And this data was then sort of passed back to us as the sort of referring institution. What we were able to do is we were able to also find and pull their liver biopsy, and this really shows the importance of having histopathologists who are interested and supportive. And again, I think reassuringly, there was not much fibrosis progression, but very similar findings in 2018 to 2024. So again, bland cholestasis, intrahepatic cholestasis, and very similar findings. So we also discussed sort of this case in our sort of MDM. We were able to obviously look at the genetics, and we had two heterozygous mutations in the ABCB11. And this is or would be described as BRIC, and perhaps that can be one of the discussion points as, should we be calling it benign recurrent intrahepatic cholestasis, or should we try and sort of evolve this, diagnosis and nomenclature? And then the question we were left with, well, this is an individual who's very symptomatic. What should the initial management steps be? So we have excellent guidelines now from EASL. And if we start sort of almost at the bottom of the recommendations, it talks about IBAT inhibition, to help reduce pruritus. Obviously in some groups of patients who may have sort of end-stage liver disease, this might be prior to liver transplantation, but certainly in those with missense mutations. Surgical interruption of the intrahepatic circulation is not necessarily appropriate in this case, but again, in certain patients with genotypes, this can be considered. And then obviously there's a long-term sort of assessment of these patients in terms of screening for hepatocellular carcinoma, and sort of ongoing surveillance. So in this individual, we were able to prescribe UDCA, and we agreed that an IBAT inhibitor would be beneficial for this individual. But as is the way, sometimes by the time we were able to organize and sort of discuss, the patient had a very rapid improvement. And maybe it was the UDCA, which had sort of slightly been started in earnest, that meant that this patient responded very well. But we were certainly ready to prescribe and initiate an IBAT inhibitor for this individual. I just want to spend a bit of time, and this is almost my summary slide about the management of pruritus. And again, this is taken from the EASL guidelines, which we've all had a chance to review, and it's really supported our sort of management of these groups of patients. And if we stay to the right-hand side where we talk about adults, that are presenting with pruritus, we have conservative treatment, which we shouldn't ignore. And these are sort of basics and practical implications for our patients, but it inevitably is not enough. And we need to think about how we can sort of improve their symptoms and improve their quality of life. So fibrates really moved into sort of our sort of treatment algorithm, bezafibrates, fenofibrates, and we feel confident in prescribing it. UDCA is always there in the guidelines, but it's important to say that it may not be sort of as efficacious as we think it will be, certainly in the management of cholestatic pruritus outside of cholestasis of pregnancy. There's rifampicin, and then there are the IBAT inhibitors. And for the guidelines, it talks about Alagille and PFIC. So this is an option for some of our patients, which we're seeing, which we're testing, and we can offer improvement. And then there are less commonly used medications, which certainly may be prescribed easily, like cholestyramine, but again, the efficacy tends to drop off bit by bit, and then we become less confident in prescribing SSRIs or even the opioid antagonists. Now, if all of these things fail, we can then try sort of, interruption of the enterohepatic circulation or liver transplantation, which sounds very extreme, but in some groups of patients, we do have to consider that. And then there are sort of more, I'd say, more experimental therapies, which aren't widely available, such as MARS or plasmapheresis. But I think the availability of IBATs will certainly help these groups of patients. And certainly in my patient, we were ready to prescribe and move forward to try and support their symptoms. So really, I'm going to finish there and really hopefully discuss how we can improve access to these medications, when we should be considering them, and try and improve the sort of symptom sort of and quality of life for our patients. So thank you.
As you showed, the IBAT inhibitor would be a quite interesting choice. There were actually quite a lot of presentations and also posters at AASLD. Do you want to comment on what they do for symptom burden and what they also do for disease phenotypes?
So I think the data from pediatric cohorts with PFIC, from the groups pediatric cohorts with Alagille show improvement in symptoms of pruritus. It's highly efficacious, seems to be safe with minimal sort of adverse or serious adverse events. So I think that's important to take away, and I certainly use that when I'm discussing starting these medications with my patients, that they're safe in children. So I think that's very important. I think another interesting poster from the ASLD was the impact on quality of life for caregivers as well to those with Alagille. And I think that was very interesting data. It was a poster. So both Alagille and PFIC, showing that the quality of life in these groups of patients is very poor, and they hope to show more longitudinal data as well of the impact for the sort of patient and the person at risk, but how it impacts on caregivers as well. So I think that's very important, and we can reassure our patients that these drugs are highly efficacious. I do think we need some more data on mechanistic sort of fibrosis data, but we can collect that going forward, and I think that would be an important place to start.
Yeah, I completely agree. And I always think, the caregivers in those PFIC children, most of them are actually carriers, and they may be the next BRIC patient we see. Although I completely agree with you, and I think Silvia does as well, I don't like the BRIC one. The name, we should rather stick to ABCB11 disease or something like that, because as you mentioned, as my patient showed, they can be progressive. It's just not good to have bile acids of 200 for too long a time period. It's just induces inflammation and fibrosis most likely.
Yeah, I think the B in BRIC, the benign, is is falsely reassuring. And I think we need to find a new letter to go there so we can sort of describe this, disease and make sure that people don't just see it once and then, sort of forget about those patients. I think we need to monitor them going forward.
And would you monitor your patient for the PFAC2 children, the guideline based on the NAPAD data, which includes quite a lot of children, actually shows the high cancer risk for those with the truncating variant. So there is even more cancer screening for HCC in these children than we do in our serotics. What do you do in your adult population? And for example, this patient with the heterozygous rare variant and the more common variant.
Yeah, I think so. With this individual, we are going to follow them up. We've said we will perform ultrasound surveillance, fibroscan surveillance at a minimum of once a year. Certainly, for them to sort of be able to engage with us. But we've clearly said we can't forget about you. I think again, by putting together prospective data registries, we can understand what the surveillance period should be, and then we can understand what the incidence of these populations are going forward as well. And there'll be a lot of cofactors, maybe marsald, alcohol, other sort of environmental factors, which again we need to understand going forward. So it's an exciting time just to be considering genetics in these groups of patients. So I think we'll learn together as we go forward.
How you do it, Silvia, in your clinical practice with your rare B subvariants?
Because I practice in a different country where we need evidence-based to actually have coverage for certain tests, that makes an extra challenge. So I think that's why also the guidelines, which I really like and I encourage everyone to read, were not be able to be done in the US, because I think the thought process, as Verena mentioned in another discussion we just had, was that there is not enough evidence base. It's all based on expert opinion, which I think I do think that the data from pediatric ABCB11 deficiency and the incidence of HCC really makes us uncomfortable not to screen for HCC. But I think that's where we need prospective data, evidence base, in order to these to be adopted widely by all providers. But I think there is something about ABCB11 and risk of cancer. Like you mentioned, I find it really interesting that even the risk, I think, is higher than people with cirrhosis. So it's something about the mechanism that I think predisposes this patient for cancer. I have a follow-up question for Deepak that is also the use of IBAT on patients that are pregnant with high bile acids. I think we all kind of also become a little bit anxious when we take care of these patients and the serum bile acid starts to go to the 3 digits and they are on the third trimester, and how quickly can we deliver the baby? How well will they do? And I think there was a poster, I think part of the Ohana study that actually is from the Kings, I believe. So you might know a little bit more data on that, that it seemed safe to give IBATs to pregnant women. I don't know if you want to comment or share any knowledge on that, because I think it's something that can be important for some of us taking care of these patients.
Yeah, I think what you've highlighted there are, women with extremely high bile acids where, there's, potentially detrimental effect for the fetus, for the mum as well. And these groups of patients are very hard to manage because, we will go through the algorithm, we will give potentially rifampicin, other medications. I've certainly performed nasopilary drainage in some of these patients, which is very anxiety inducing for the mother, but also for me. So we have used IBATs in pregnancy in a few women sporadically. We consent them. I think it's an area which we need to certainly sort of invest in more, and we can show that the data, it is safe. It is safe for both, for the mum and for the baby as well, and it's highly efficacious. So I think my colleague Kath Williamson is certainly, working on this. There was, like you said, some data at the ASLD and previously, but we just need to sort of, understand and promote that IBATs are safe for those who take it. So I think we'll learn more about it going forward, and I think there'll be more uptake this time, hopefully.
Yeah, I think it's a very, very unmet need and a very important topic, but also, like you mentioned, difficult to enroll because to do studies in pregnant women is always a challenge.
Yeah, but I think as we move more of these pediatric cohorts into adult medicine, because now with therapies available, there may be more native liver survival. So we actually see them without a transplant. We will also gain more insight into the treatment options, how long we can prolong their native liver survival, what this means, for example, to become pregnant under these conditions as well. So I think this is very exciting because in the past we only saw them with a new liver in, but now as adult hepatologists we may see them with their actually native liver.
Yeah, I agree. I think, again, as we evolve, we'll see them coming forward. They will be on their IBATs, and we will have prevented liver transplantation. But as they potentially get pregnant or develop sort of other normal or sort of parts of aging, we'll sort of understand more as well. So yeah, definitely very exciting.
Yeah, I think the future is really, at least there will be a subfield of like genetic hepatology, because there's like with the improvement of these patients and all the needs, it's something that we want more people interested in diseases like we are, I think, which I think is also not so common in adult hepatologists. Like they really are interested in more what is seen as common diseases, but I think these will altogether will start becoming really a substantial number of patients that we will need to manage that previously were not there.
Yeah, I mean, the three of us, we are definitely hereditary liver disease enthusiasts, but I think there's even more therapies to come with all the mRNA technology, base editing, and as I said, the small molecule we saw. So we might target not only the gut, but also the liver. So I think we have exciting times ahead, but in order to treat these patients, we actually need to detect them. And I think, Silvia, you said it really nice. We need to find them we need to understand them, and then we can treat them and improve also their quality of life and those of the family and friends around them. And I think it was really great chatting to you two, seeing the presentations, and hopefully we found an audience that thinks about genetic cholestasis now, knows to also look at this in hepatitis-like presentations, the genes your geneticist can actually find, and keep looking, and you will be successful in identifying these patients. And thank you to you two for your presentations, for your time, and for these lively discussions.
Thank you. It was a pleasure.
Yeah, thank you. Really enjoyed it. Exciting times.